on this year at a conference. And so I'll let you take it over, Michelle. Before you start, just make sure you give an introduction about yourself, where you are, etc., so we can let everyone know.
Yes, absolutely. Just checking that you all can see my screen okay. Okay, yeah. Great. Thanks so much, Hannah. That was also a really wonderful presentation. I learned so much, and I will definitely be referring to those slides. So thanks. So by way of background, for those who don't know me, my name is Michelle, and I am a newly finished second year, incoming third year into the clinical psych doctoral program at VCU, with many more years to go. But my background is actually in public health, specifically global women's health, prior to coming to VCU. I became really interested in psych and substance use while doing work abroad in Zambia and Ethiopia, which kind of led me here. So my advisor in the psych department is Dr. Dossie Svikas, who you probably know is a cherished member and collaborator of the Ivy Lab. So in coming to VCU, I've been getting much more experience with women's health psych and substance use, and getting involved with the Ivy Lab for the past year and a half or so, which has been a really incredible experience. So I've been working with Dr. Martin on Project Better and Project Sort, which you might be familiar with. But this project specifically is analyzing secondary data from the Postpartum Recovery Project, or PPR, as you might have heard about before. So this study enrolled, because I think we finished enrollment and are doing follow-up now, pregnant people, and follows them until 12 months postpartum to evaluate how people recover postpartum after the delivery of their babies, and to kind of better understand what recovery means and what factors might impact recovery after having a baby. A lot of preamble, so I'll go ahead and get started in the background. So postpartum mental health is an increasing public health priority for a lot of reasons, especially as we become more aware of the impact that postpartum mental health can have on not only maternal outcomes, but infant outcomes as well. So we often think about postpartum mental health in the context of postpartum depression or anxiety, but the childbirth experience can be a really component of postpartum mental health. So the childbirth experience can be distressing to postpartum people and sometimes even traumatic. So a negative birth experience could cause psychological distress and intense fear in the parent in the short term, and increase the risk of mental health conditions such as anxiety, depression, and post-traumatic stress disorder, or PTSD, in the longer term. So post-traumatic stress really does have implications for the relationship between the parent and the baby in the longer term, as well as it relates to bonding in the dyad. And anxiety and depression tend to get a lot of the postpartum mental health real estate, which is very understandable. But post-traumatic stress and trauma may actually be as common, if not more common, than anxiety and depression. Because I know that not everyone here on this call is a psychology person, but a lot of people on this call are clinicians, I wanted to touch a bit on what post-traumatic stress might look like immediately postpartum. So the parent might be feeling or expressing a lot of anger towards medical staff, hyper-focus or really alert and responsive to monitors and alarms. And as you probably know, there's a lot of monitors and alarms going off in that clinical setting. If the baby is in the NICU or somehow separated from the parent might avoid visiting their baby or avoid bonding experiences with their baby. The parent might experience sleeplessness, but this is common with all parents postpartum. So kind of looking at the background factors that surround that. And then the parent might experience and express excessive guilt over certain components of the childbirth or pregnancy or postpartum process. And I also want to highlight, I'm using a bunch of different terms, but I want to highlight the difference between post-traumatic stress symptoms, PTSD-FC, which is PTSD following childbirth, and acute stress disorder, as it's important for later in the presentation. So Post-traumatic stress just refers to a group of symptoms that indicate clinically significant stress in the postpartum period. Experiencing post-traumatic stress might indicate a diagnosis of ASD or PTSD-FC. So the first month post-trauma is acute stress disorder, and then more than 1 month post-trauma would be post-traumatic stress disorder. So now I want to shift focus a little bit to how this might impact a population of interest, which is birthing people with OUD, who often experience unique challenges with labor and delivery. I know this might be review for some of you, but some of these challenges include difficulty with pain management, concern over the involvement of child welfare in their new baby's life, stigma, comorbid mental health issues. Such challenges may increase the risk of experiencing post-traumatic stress after birth, but this is purely a hypothesis because from my knowledge, no study that I've found looks specifically at post-traumatic stress after birth in this population. I say this with a huge asterisk because I did not, in fact, do like a systematic review like Hannah showed that really nice Excel of kind of extracting variables from different studies. I did not do anything of the sort. It was a lot more informal, but from my preliminary scan of the literature, I couldn't find studies. So if you know of any, let me know. But it's the fact that there is this kind of gap is really important because not only can post-traumatic stress disrupt bonding and healing for families, and we know that in the general population, but in our population of interest, it may impact recovery, which has a whole kind of host of other implications. And so this is really important to look at also because opioid use has increased in the US, impacting pregnant and parenting people in particular. I know this might not be news to you and this graph might be very familiar, but it kind of highlights the national prevalence of OUD at delivery hospitalization from 1999 to 2014. I'm sure there's some updated graph, but this kind of demonstrates that opioid use among this particular population has increased and continues to increase. So more research is needed to better understand post-traumatic stress after birth in this population and factors that might be associated with such stress. And this is especially important with the landscape of increasing opioid use. And such information could help develop just clinicians, researchers develop tailored interventions around post-traumatic stress and improve the health of the parent-infant dyad. So the objectives of this study were to characterize post-traumatic stress after birth among women in OUD treatment during the early postpartum period, and then to explore the relationship between such stress and attachment, perceived control in childbirth, satisfaction with pain management, cravings, and anxiety and depressive symptoms. So as Dr. Martin mentioned, I'll be presenting this data. It was accepted for a poster at the College on Problems of Drug Dependence in mid-June. I know Dr. Martin and AB are going to that conference. I hope that some others are going. I'd love to meet some of y'all in person. So this study was a secondary analysis of baseline data from a longitudinal study of women in outpatient OUD treatment. So the parent study, as mentioned, postpartum recovery, just finished enrolling adult women receiving buprenorphine for OUD in their 3rd trimester of pregnancy and following them up to 12 months postpartum. So now we're in the process of following up with the women who were enrolled and the data analysis phase, which this is kind of a part of. So there are a lot of measures in the postpartum recovery project, but we took several measures from baseline and 2 weeks postpartum in the current study. So the one used to characterize post-traumatic stress was the PTSD checklist civilian, or the PCLC. And you can see the ranges here from 17 to 85, and scores of at or above 29 indicated post-traumatic stress measured at 2 weeks after birth. And participants identified the index trauma from the following categories: pregnancy, birth, an infant medical issue, or a previous unrelated trauma. So when I say identifying the index trauma, that just means that they were asked which of the following events was the most traumatic over the past several weeks. And I also want to highlight, so this is not a diagnosis of PTSD. So scores at or above 29 just indicates clinically significant post-traumatic stress. So more measures, a clinical exam, assessing the temporality of the symptoms would be needed to kind of support an official diagnosis of PTSD or even ASD. So because this is such an important part of the study, I want to highlight what the PCLC measures, more specifically for those who might be unfamiliar with this checklist. So the prompt was, below is a list of problems that people sometimes have in response to a very stressful experience. So reflecting on this traumatic experience that you just selected above, please indicate how much you've been bothered by each of the following problems since delivering a baby. So there's 20 questions, and here's a little sample, and it's on a Likert scale from 0 to 4, ranging from not at all to extremely. So these questions included questions such as repeated, disturbing, or unwanted memories of the stressful experience, suddenly feeling or acting as if the stressful experience was actually happening again, among some others listed. So I'm happy to provide the measures for people if they want to see it. So as noted, postpartum recovery conducts a lot of measures, but the ones that we included because we kind of hypothesized they might be associated with the experience of post-traumatic stress were maternal attachment, perceived control in childbirth, satisfaction with pain relief in the labor process, cravings, and anxiety and depressive symptoms. And I included the ranges here to provide context to some of the means that I will show later in the presentation. So first I did some descriptives, but then attachment, control in childbirth, satisfaction, cravings, and mental health symptomology between women with and without post-traumatic stress after birth were compared using t-tests. And for those who aren't super familiar, t-tests kind of look at the differences between means between two different groups and sees if there's a significant difference. Future analyses will continue to use these measures to explore the relationship between these variables as the sample size hopefully increases as women continue on and follow up in the study. So now for some of the fun stuff, some results. So some of the demographics, it was a sample size of 18, which I do want to note is a smaller sample size. This is important to note. So in the parent study, it's a smaller sample size, but really in-depth measures and observations for each of these participants. And the sample is predominantly white. The mean age is 30 and primarily unemployed and married. So interestingly, of the sample of 18, nearly half, or 8 postpartum people, endorsed symptoms of clinically significant post-traumatic stress after birth. So meaning they reached that threshold of 29 and above. 2/3 of these participants attributed symptoms to a birth or infant medical issue. And this included the baby being hospitalized or the baby being admitted to the NICU within the 2-week time period postpartum. And then as you can see in the chart, the other third indicated that the index trauma was related to an unrelated previous traumatic event. And so then some of the findings. So some really interesting findings, although I want to note they were not significant. So this is potentially an issue of a very small n, just comparing 8 people to 10 people, which might be addressed if there are more observations, as there just simply might not be enough observations to detect significant differences between the groups. But then in looking more closely at the means, so women with post-traumatic stress had lower satisfaction with pain treatment at delivery and higher reports of cravings. Women with post-traumatic stress also had more symptoms of anxiety and depression than those without post-traumatic stress after birth. Interestingly, maternal attachment was generally quite high. So the highest possible score for maternal attachment is 26, and the kind of lowest score, because it's kind of negatively evaluated, is 104. And so across both groups, it's 27, 28, which is pretty high and also kind of a good indicator. And perceived control in childbirth was also quite high. So the highest score, possible score is 60. And so interestingly, you can see that those who endorsed post-traumatic stress had higher perceived control in childbirth than those without post-traumatic stress. But again, I do want to note that these results were not significant. So I'm just, making the observation that the means were higher and lower, but more observation could maybe help us detect clinically significant differences. So kind of the take-home points. So there's a need for more research on post-traumatic stress among larger samples of pregnant and postpartum people receiving buprenorphine. Qualitative research would also maybe help to understand such experiences, to understand what specifically about these experiences was perceived as traumatic, and help to identify risk factors for that experience. I think there's a lot of opportunity here for some research, which I hope to do. So hopefully I can collaborate with some of you on this, because I think it's really interesting. And so evidence-based screening and trauma-informed care after birth for postpartum people in OUD treatment are recommended. So these findings suggest an area to address with patients and clinical interactions in both the prenatal and postpartum period. And that is my presentation. I look forward to any questions, any feedback that you might have. This is an evolving, it's a works in progress. I have this poster, but I hope to do a little bit more with it. So with the project in general. So I really look forward to your feedback. And then here's some questions if you need some jump off point.
Thank you so much, Michelle. That was great. It was wonderful to be able to see the results. They're very sad results, but it's good to use numbers and use research to bring awareness to a topic that we anecdotally, I can say, clinically talk about all the time. But to be able to see that reflected in the numbers is pretty empowering to know, okay, what we've been noticing clinically with this issue is significant, and we need to dive more into it. So yes, thank you so much.
So Michelle, I had a question. So great job with the presentation. Just something about PCL5, like I heard the same questionnaire in another presentation last week, and probably some questions that I'm just repeating because they weren't clear at that time. So do you know the baseline scores for your two groups for PCL5? Or did you already present it? I don't know if I missed it during the talk.
Like the overall means for the two groups?
Yes, yeah.
I don't offhand, actually. I have it somewhere in a data set, but I just kind of reported on who reached the threshold of the scores of 29 and above.
Okay, so do you think that somebody who didn't know that they had PTSD could be diagnosed with PTSD, not diagnosed, but clinically have PTSD after doing the questionnaire?
Oh, that's a really good question. Given that I'm like so new to clinical work, I'm curious if more other people on the call who have more experience with this, but I see how kind of like reading through the questions and being like, oh yeah, I am having these symptoms, and kind of reading that and reflecting on their own experiences can help them realize. The PCLC is really helpful. It's a good screener. Like to get an official diagnosis of PTSD, I feel like, I know I keep reiterating, but using the screener is just one part of the process, right? So like the temporal aspect has to be assessed, but it is a really like great way to clinically see who's experiencing these symptoms in the clinical setting. Yeah.
Yeah, no, that's what I was just wondering, is because I know in the clinic sometimes we have those screening for IPV. I'm just wondering if you find somebody who has a score of 29 and more, do you then refer them to somebody? Would you do that, or is it just like, as you said, a screener? So because it's just interesting where you don't need to have a clinical diagnosis by a physician or somebody, and then you come to and do this questionnaire with your recent experience. Do you then have PTSD? So that's what, because this screening doesn't even tell you if it's like mild, moderate, or severe PTSD, right? It is just, right. Okay.
I might have to double check on that, but I believe so. But that's a really good point, is like how it is used in a clinical setting. Like, because I've been looking at studies, right, that have used the PCLC but not how it's like clinically used. So if it was identified in like a primary care setting, and I'm thinking this is the PCLC, so the civilian version. So it might be a little different for like veterans or military members. But if it's used in a primary care setting, what are kind of the follow-ups needed there, and who, I guess, do they refer to, and who's kind of responsible for initiating care in that realm? Or is it more of like a cautionary thing of just be aware of the symptoms that are present in this person moving forward?
Sorry, just one last question is, are you just using this for your baseline measure, or this or PCLC will be measured later at the end of follow-up too?
The PCLC is used at several different points in postpartum recovery. I haven't looked at it beyond, so this is specific to the PCLC after birth. So at other time points when the PCL is used, it's different kind of questions about the index trauma and a different reflection on the traumatic event. So this PCLC is specific to the birth experience. But I think it could be interesting to see it over time, and like how the trauma symptoms might increase or reduce. Yeah, it's a good suggestion.
Thank you.
Thank you. I want to add a couple of things to Bhushan's points. We didn't really think about, when we were doing this study, about the follow-up periods for specifically this like childbirth trauma. And so we switched also to help shorten the surveys, because they're very long and have a lot of things. We switched to like a 5-question PCL. So it's much shorter and it doesn't give all of this information. So we can have an idea for later in postpartum, but it's not as detailed as this one at the 2 weeks. And then I was also just going to add that I agree with Michelle that we didn't do any follow-up on these because it was just for research. But if you were to use them in a clinical setting, it is my opinion that it would be like clinically irresponsible to not follow up if you are using this screener. And so like we have used them in primary care and then work on treating those symptoms as like a primary care provider, or you could use them to like educate other clinical staff about trauma-informed care. And so if, these symptoms are really common, then you might approach the patient differently, or, have more compassion and understanding when they're getting irritable and agitated, or like things like that. So I definitely think it would inform care, even if it's not a diagnosis.
Michelle, if you go back to the slide with the outcomes, yeah. So I found this interesting, the perceived control in childbirth. It looks like those who perceived control in childbirth were, there was a higher number for post-traumatic stress. And I would have mentally thought that might be the opposite, that when you have control, the stress afterwards would be lower, because sometimes, we've learned, when people are feel out of control, that that stress level is higher. So I guess what I'm wondering is, were there any, was it just one question about control? Like, did you feel like you were in control, or was there any further questions in that area?
That's a great question. Yeah, it's a full measure called like the perceived control in childbirth scale. Annabeth might know more specific, like what the questions are. I'm happy to send it to you, but it goes through different domains of, it's not just, did you feel in control in childbirth?
Right.
0 to 10. It's a full scale. Yeah.
Oh, yeah, I think that would be interesting. I would personally be interested to see what that was. I don't know if having that control added stress in this population, that they felt they had to make a decision. Because, clinically, I've always thought of it the opposite way.
Yeah.
Provide people the access to having self-control and being a part of their decisions, but maybe in childbirth, you don't want that. I don't know. I just find it very interesting. I'd like to see more information on it. That surprised me. But thank you so much for all of your work.
Yeah, no, that's a really interesting point. I'm curious by that as well. I'll have to do some more digging. But yeah, thank you for sharing your own clinical experience and like what you've seen anecdotally. I think that's really important.
Yeah, Margie, your inclination, I think, is correct from other populations. So I don't know if any of you all have met Dr. Williams, Allie Williams, who's a psychologist who's in the NICU now. She did her dissertation on something similar and did find, and I think she included it because a few other studies had found that having less perceived control did tend to increase that post-traumatic stress. So people that felt out of control. But you're right. I think that it could be different for this sample, and also this sample is really small, so these numbers might not really mean anything. But I can't remember off the top of my head the different domains, but it was like there's like questions about communication, and if people like told you what was happening, if people listened to you when you made a request kind of thing about your care. If you like understood what was going on while you were having a procedure or different things going on. So yeah, it's a really detailed questionnaire.
Mhm.
Thanks, Annabeth.
I have a question, sorry.
Yeah, go ahead.
Sorry. So if you go back to the same slide that you were just on, there is maternal attachment that's higher in post-traumatic distress patients. I guess, how did you measure that? And the reason why I'm asking that, I would guess any mother who just had a baby would have some inherent attachment to their child.
Mhm.
And why is it higher in PTSD patients as opposed to just non-PTSD patients? So there are two questions, I guess.
Yeah, that's a really good point. And the measure is called the maternal attachment inventory. And it, as I noted, it's scored from 26 to 104. So 26 being like the highest possible score or the highest amount of attachment possible, with 104 being kind of the lowest. And so you can see here, I mean, first of all, again, not statistically significant, so take it all with a grain of salt, but they're both pretty similar across those with post-traumatic stress and not post-traumatic stress. So 28 versus 27 out of a possible, like the highest possible being 26. So I think that actually indicates like pretty high attachment among this specific sample. But I am curious what the differences would be in maternal attachment, because I'm not sure what could lead to even this small difference.
Thanks.
Yeah.
Yeah, I'll just follow up there. I think they found a lot with research that maternal attachment is really impacted by depression. Postpartum depression, where they just feel detached. They literally will say they just don't feel anything towards the baby. They don't, a lot of times they can't even think of a name. What do they want to call the baby? Those types of things. So I don't know if we're catching depression versus stress, or it's all kind of wrapped in there. But anyways, we do know that depression is huge, postpartum depression, as far as maternal attachment goes.
Yeah, that's a really great point. I'll have to look specifically at the maternal attachment inventory, but we do capture postpartum anxiety, or just symptoms of anxiety and depression postpartum using the PROMIS scale. And you can see some of those findings here, but it would be interesting to look specifically at the relationship between attachment and some of the mental health symptoms.
Thanks, Margie.
When you guys were talking about that, I was just thinking about, you know, how much resilience I think this data kind of shows too of the ladies in our study sample. The women who did this study is kind of a select group already, because the study did take a lot. Women had to be on buprenorphine, and so it's not representative of our entire clinic. It's a select sample, but nonetheless, I was just kind of reflecting on, when we're talking about all these things, despite something like post-traumatic stress in the context of everything else our patients are having to go through and their families are going through, they still had this like super high attachment score, right? And they're still in treatment, for the most part at this point, et cetera, all these positive things. So I was kind of reflecting on the resilience aspect of the sample, especially, and I think that also limits your generalizability of the results, Michelle. But nonetheless, it's a positive spin, or not a spin, but it's positive conclusion that we can take from some of this data. I do think that there's a balance, though, between this like resilience of like what we're noting with the maternal attachment scores being so high across both groups. And I know it's not statistically significant, and I know it was your exploratory second aim was to comparing these outcomes. I know your primary aim was just describing the trauma, but I mean that anxiety and depression, it is slightly different between these two groups, even if you just break them down. And so there definitely is something going on here. But I think at the end of the road with this sample, the story is resilience, right? Despite everything that's going on, these women are, kicking butt, right? And they're doing, they're really working on their recovery. But it doesn't mean that we don't need to do something about it and pay more attention and be better about being trauma informed and how we care for this population, especially as they transition between inpatient and outpatient.
Mm-hmm. Absolutely. Any other questions or thoughts before I wrap up? Great. Thank you all so much.
Thank you, Michelle. That was great. Excited to see what we can do to continue the project moving forward. I know we've talked about adding a qualitative component potentially, and getting to hear the stories from our patients to kind of complement. I think that's kind of what we've talked about. So I think that would be really great if we can do that in the future, because it's really important. And Margie can attest that this topic has come up a lot in our meetings about our patients. So definitely an important topic. Great. Does anyone else have any other comments or questions? Okay. Well, thank you everyone for coming out and sticking with us this late in the evening, and for coming to our last lab meeting. I appreciate all of you. And as always, please reach out to me if you have any questions, concerns, or ideas for next academic year. And we will see you in the fall. Bye, everyone.